Good afternoon, good morning, good evening, wherever you are. Thank you for joining this webinar on health system challenges of providing second trimester surgical abortion. Today, the presentation is going to be done by Dr. Hannah. Dr. Lamy was supposed to be the moderator today, but because of some unforeseen events that he will not be able to join us. So I will be sitting in for him. My name is Farid. I am a consultant OB/GYN at St. Paul Hospital in Medical College. I am also a family planning and reproductive health specialist working in the hospital. I see people are still joining. So in the next 5 minutes, we will start our session and Dr. Hannah will take the floor. Thank you everyone for joining us. Greetings once again. I think we can start now. Just to introduce our panelists today, Dr. Hannah is an OB/GYN, a spirit consultant OB/GYN, working at St. Paul Hospital in the Medical College currently. She is also a family planning and reproductive health fellow during her second year fellowship. She has tremendous experience in working in developing countries in terms of providing family planning and comprehensive abortion care. He's also a researcher and an advocate for women and girls. So without further ado, I will leave the floor for Hannah. Dr. Hannah, over to you.
Good morning and good afternoon, everyone. I will discuss on health system challenges of providing second trimester surgical abortion. I don't have any conflict of interest to declare regarding materials discussed in this presentation. So these are my outlines. I will see some of the introduction and I will discuss some on medical and versus surgical methods. And we will see on factors associated with second trimester abortion, WHO health system framework, and challenges based on the health system framework. And finally, we will see on how we address the challenges. So to start from the introduction, worldwide, 10 to 15% of the abortion performed annually are second trimester abortion. So the abortion mortality increased when the gestational age increased. In WHO 2012, as it is seen on the graph, it shows at 10 weeks or earlier, the risk of mortality 0.2 per 100,000 abortions. At greater than 20 weeks, the mortality become 8.9 per 100,000 abortions. So with the gestational age become more advanced in the second trimester, the mortality will increase. So access and availability barrier were more prominent in second trimester comparing with the first trimester abortion. The approach for second trimester abortion, which is recommended by WHO, are DND, and the other is use of repeated dose of prostaglandin with or without mifepristone. But if there is no availability of mifepristone, the recent WHO recommends the use of letrozole. In countries where second trimester abortion service are extremely limited, like in Ethiopia, the complications of second trimester unsafe abortions are expected to be very high. So when we compare the medical to surgical methods, DND is the predominant method of second trimester abortion in some countries, like in US and some European countries, they prefer more DND. So in 95% of second trimester abortions are completed with surgical methods, but which is the opposite for sub-Saharan Africans. Medical abortion is more common. And both the methods, both the medical and surgical methods, are safe, effective, and both methods are acceptable. So the choice, it depends on the client preference and also the clinical condition of the client. So when we see the factors associated with second trimester abortion, so when we say the factors associated with second trimester abortion, so these are the factors that leads a woman from first trimester service to go to second trimester abortion service. There are two factors. One is the client factor and the other is the health system factor. From the client factor, age is one of the factors. So those who are young are due to diagnosing of the pregnant, they may go to second trimester abortion, and the other is distance, education, ambivalence, late recognition of pregnancy, stigma, and anticipated change in personal circumstance, like when there's a divorce with marital or separation with the partner, might be a factor that leads a woman to go from first trimester to second trimester abortion service. The health system factors are the distance, if there is no functional health facility, or if there is poor knowledge of abortion legislation and availability of facilities, equipments, drugs, and trained providers. And if there is also health system barriers, if there's a barrier of referral and also having guidelines and difficulty in obtaining woman-centered abortion care, the health system factors that lead a woman from the first trimester abortion to go more to the second trimester abortion. So there is a survey which is done on second trimester abortion in United States, and this survey, it shows almost 50% of the delay in the delay was by difficulty in making arrangement for the procedure. So when we see generally the challenges for second trimester abortion service are, first is availability of the providers. The other is the limitation of training for second trimester abortion, emotional issues, the negative connotation of abortion, harassment by opponents of abortion, and even when the providers are, when there is a violence to providers, and high cost of second trimester abortion service, and legislation and government regulation are also other additional barriers. This is a study. It shows access to second trimester abortion is severely limited. So 9 to 10% of all facilities have a provider who can perform this service. So there is in a study done in IPAS, which is done in Ethiopia, access to second trimester abortion is 9 to 10%. And there's also another study, a national study of, done on the availability of safe abortion in Ethiopia, indicated that the national achievement in access to and availability of comprehensive second trimester abortion is 24%, which is very low. So before we go to the challenges for second trimester surgical abortion, I will see what second trimester surgical abortion is. It's a DND which was done. So the DND, to do safe DND procedure, there are requirements. So from the requirements, one is cervical preparation agents are the first thing we need to do for DNDs. Other is a skilled and experienced surgeon in provision of the DND, and adequate pain control option also need to be appropriate for appropriate monitoring. And there is a requisite instruments for the procedure, staff skilled in patient education, counseling, procedure care, and patient recovery. And it needs also a freestanding facility for transferring patient in a case of emergency, in a case of required emergency hospital-based care. So I will discuss the health system challenge based on the WHO health system framework. The WHO health system framework, it has 6 building blocks. These 6 building blocks, it will give us the outcomes, the 4 outcomes. So the 6 building blocks are the service delivery, health workforce, health information system, access to essential medicine, financing, and leadership and governance. So with this, we can assess the outcomes of improved health, responsiveness, social, financial risk protection, and improved efficiency. So starting from service delivery challenge, the service delivery challenge is affected with, one is with availability, the service availability, and the other is the service readiness. To see the service availability, facilities had major shortcomings in providing women-centered second trimester abortion care. And it's a major obstacle to obtain care, and distance can also discourage people from even trying to reach care. In most countries like Ethiopia and some sub-Saharan countries, second trimester abortion is done in referral hospitals. So due to that, clients from district sites are referred to town, but during the referral time, there is no arrangement of transportation issue except for those who are life-threatening post-abortion care. And the cost of second trimester termination of pregnancy was found to be very high, because if they are going to be referred and if there is no any arrangement of transportation, so a woman will cost her with the travel cost and also day-to-day expenses until the service are provided, makes the overall cost of second trimester abortion inaccessible. So because the service is provided in limited hospitals. When we see the service readiness, in most facilities, there is no written clinical or procedural protocols addressing the provision of second trimester abortion. And there is also lack of space which is dedicated for second trimester surgical abortion. So women who came for second due to lack of this service readiness, women might face to continue the pregnancy, and most of the providers might tell her to continue the pregnancy without her will. So generally, distance, cost, and quality of service are interrelated factors that a client or a patient and their families have to negotiate with. So when they are considering seeking service, or once they have decided to seek the service. The other challenge is the health workforce. The proportion of all providers trained in either pre or in-service training for second trimester abortion is very low, especially for surgical abortion. It's very low. So refusal by proposal to perform abortion or refers due to even a religious or cultural belief of or lack of skills of the health worker is another challenge. So the health workforce challenge are two. One is the number of trained providers, and the other is the negative attitude of the provider. When we see the knowledge skill gap of the providers, there is one assessment done in Ethiopian Safe Abortion Guideline. In this assessment, it shows regarding the correct method for second trimester abortion, less than 50% of the providers identified the recommended method, and more than 60% cannot identify the recommended method. And in this assessment, they assess also the knowledge score. So knowledge score of greater than 70% of the providers were attained by greater than 70% on the recommended method for second trimester abortion was attained by 2% of all the providers. So when we come to specific second trimester surgical abortion, the DND procedure requires more active provider involvement. So a continuing challenge to provision of DND is the availability of large enough pool of skilled providers. So it's not only the provider which do the surgical abortion, and also the supporting staff like a dedicated team involved in pain management and service provision is also another challenge. And acquiring second trimester surgical abortion skill can be challenging, since many training programs also fail to provide adequate instruction. And in graduate medical schools and even postgraduate for obstetricians, DND still remains less likely to be taught than the first trimester surgical abortion, like vacuum aspiration. The other is the negative attitude of the provider. So some providers might find it distressing to perform DND at advanced gestational age. So they will refuse to give the service of DND for a woman who came at second trimester. And the other, the effect of social, cultural, and legal concern due to their beliefs, their misinterpretation of the law, they may refuse to give the service. And the other one is the health information system. Health information system is a core point which increases the quality of the service. So if there is no data, quality of service cannot increase. But what we see in surgical abortion, specifically D&D, there is no integration of specific indicators for the quality of second trimester surgical abortion care into the national HMIs. As we know, medical abortion, comparing with surgical abortion, it has controlled pain, so the pain can be controlled. So comparing with the medical, it has less pain. And the other thing is the time it takes to do the procedures. Once the procedure starts, the surgical abortion, it might take shorter than the medical. So this should be clearly written as an indicator for the national HMIs. So if it's not written, so it cannot increase the quality of the service. So the health information system is a challenge also for doing surgical termination. The other is accessing to essential medicines. When we say access to essential medicine, it includes also instruments and medications. So there is a shortage of mifepristone, misoprostol, and cervical preparation materials like laminaria is seen, especially in some nations which are far from the foreign markets, which needs foreign currency. It might be very difficult to avail this kind of medications and cervical preparation materials. And there's also equipment and facilities for D&D is not available in most of the facilities. Cervical preparation agents like laminaria, dilapan, Lamisil, these are the osmotic dilators, which are a very important materials. It facilitates atraumatic cervical dilation, but these agents are expensive, especially expensive for low-income countries. And unavailability of some instruments, like when we need specialized speculums or some different cannulas for difficult cases, it might be challenging to get these instruments. And even though it is available, and once it's available, easily replacement of materials when they are lost or out of function is a big challenge. And getting dedicated and fully equipped place for advanced second trimester abortion is also another challenge. When we see the financing, financial saving can be made by maintaining or even improving the quality of abortion care service. So what we see on second trimester surgical abortion, there is a scarcity on budget allocation and funding for commodities important for surgical abortion. So it's not only allocation of the budget, but once even the budget is allocated, there is a lack of sustainability to purchase instruments and supplies that will needed to be restocked regularly, like as we said before, the cervical priming agents, coils for the procedure, and D&D sets. So financial protection is restricted to specific demographic groups of individuals who seek abortion. Leadership and governance, it's very important. Risk of prosecution for second trimester termination of pregnancy is seen in some of the countries. So due to this, there is some providers may choose instead of either to stop performing D&D altogether or to sustain to substantially reduce the gestational limit to first trimester. So they will avoid to do second trimester surgical abortion. So the bans may also have it has significant chilling effect on the training. And there is misinterpretation of the law by the providers. So the leadership and governance should see should see what's done on the ground about the misinterpretation of the law. And finally, when we see how to address the challenges, providing universal access to sexual and reproductive health and reducing the global maternal mortality rate to less than 70 per 100,000 live births by 2030 is a key to attainment of the Sustainable Development Goal. So the provision of safe abortion is a critical part of meeting this goal. So how do we address the challenges? Addressing the myriad of factors hindering access and availability of the safe abortion care requires multi-pronged strategy. One of the strategies is early identification of unwanted pregnancy and accessing early termination of pregnancy. Once they go to second trimester, we should have to provide a woman-centered and effective or safe methods of abortion for second trimester. And the other thing, we need to do capacity building initiatives needed to prioritize hospitals used for training of obstetrician, general practitioner, and health officers in their initiation and scale-up activities. And we should have provision of early second trimester termination of pregnancy at carefully selected health centers staffed with less specialized staffs, and incorporate value clarification in all abortion care training and programs. And we need also to educate the educators. That means we should show this for the media professionals, teachers, healthcare providers, and young people about safe abortion option. And we should advocate for affordable and accessible abortion care service, especially safe second trimester surgical abortion care for rural and poor women and students who are vulnerable and who cannot access the facility of second trimester surgical abortion. Thank you. This is all about the challenges of second trimester surgical abortion. If you have any question, comment, you are welcome.
Thank you, Dr. Hanna. This was an excellent presentation and a good overview of what are the actual challenges on the ground that we have day to day in our practice, especially relevant for those who are clinicians as well as program managers. Having said that, there are a number of questions for you, but if there are anybody who wants to go live and ask questions, I think we can open the floor. The Q&A box is also available. If you want to text your questions, please feel free to do so. If there is any questions. Okay, so let me forward a few questions to you, Hannah. So one of the questions that we probably get most of the time is, you know, why should we even try to invest on surgical abortion given there is an effective, safe method of termination of pregnancy, which is medical abortion? So what would be the need to invest on surgical abortion?
Thank you, Dr. Farid. It's a good question. So yes, we know that medical and both surgical are both effective and both are acceptable and safe. But still, there are some difference comparing medical to surgical, especially when we compare based on the pain and also based on the time it takes for the procedure. There's some difference. So when we see the medical with the pain, we can control the pain, we can give analgesics, but when we see the surgical abortion, usually we use medications that will decrease the pain, so we can control the pain. So comparing with the medical, they have less pain. And the time of the procedure also for medical, so we just wait until it completes with the giving of the medication. So in surgical, usually they can have like as outpatient, and it may take a short time of doing the procedure. And the third one also, in some countries, which is not free to have the second trimester abortion, even having a surgical abortion as outpatient, it might decrease also the cost. So with this, we should give the choice for a woman or for the pregnant person. So it should be her choice after we tell her all this. Thank you very much.
Okay, I think that's a very point on into what would be the need in terms of investing on surgical abortion, given there are some clinical and non-clinical benefits, especially in terms of the better occupancy rate, less pain, less blood loss. That would make sense in terms of investing on surgical abortion. The other point is also, as you said, not all patients are eligible for medical abortion. Some patients will have contraindication for some medications used in medical abortion. So for such cases, again, having that option of surgical termination of pregnancy will be highly relevant. So I see one hand up, Mesfin. Please go ahead.
Thanks. As we know, the government of Ethiopia focuses on first trimester surgical abortion, but why not the government focus on second trimester surgical abortion? That is my question.
Thank you, Masman. It's a very good question. Yes, we know that the more focus is on the first trimester abortion. So comparing first trimester abortion and second trimester abortion, most of the abortion services are given for first trimester, and it's not common to have second trimester abortion. So it doesn't mean that focus is not given, but what we need for second trimester abortion, it needs a better trained person. So probably it is because what we see is in the first trimester and post-abortion care, so more focus are given on the first trimester training, but it doesn't mean that it doesn't need to have second trimester abortion. Even when we compare our country or some nations, sub-Saharan nations, comparing the number of abortion in the second trimester, it's somewhat higher. So still we should work on that, on training of providers to give a second trimester abortion service. Thank you.
Thank you. So on the chat, we have a few more questions. So one of the questions is about the difference in challenges between second trimester surgical abortion and medical abortion. How are the two different in terms of the challenges?
Okay. Based on the rights, it has no difference. So there is a gestational limit of, they are in different nations, in different countries, they have their own limited gestational age. For us, the limited gestational age is 28 weeks. So it's the same. The charge is the same, whether it is in the first weeks of the gestation till the 28 weeks of the gestation.
I think it will be also more important to talk about yes, I mean, we know as pregnancy advances, the risk of complication will also increase, be it a medical or surgical abortion. So the challenges for medical abortion will include, adequate pain management, especially as pregnancy advances, and the fact that there is going to be a need for, at least at this moment, the evidence suggests that the second trimester abortion cannot be done as outpatient, so some dedicated facilities should be needed. But when it comes to surgical abortion care, the outpatient setting can fully accommodate the need of the client. So that is one difference in terms of that. The other is that the level of training that is needed to provide surgical abortion will be a bit higher, as Dr. Hanna mentioned earlier. Not many facilities will have that capacity in providing surgical abortion, and as well to the commodities. So before we proceed to one of the question is probably for Hannah, one more. You mentioned some of the commodities being a challenge for provision of surgical abortion, like laminaria, for example, which is really essential in terms of reducing complications. So what would be expected level of commitment from Ministry of Health, care providers, program managers, in terms of ensuring these essential commodities, such as the speculum you mentioned, which are really makes your life easier when you do the procedure.
Yes, thank you, Farid. Yeah, as we know, laminaria and other osmotic dilators are a very important materials, or these are very important commodities, which is important to do second trimester surgical abortion. So it will decrease even the complications, even it will decrease the morbidity of the woman. So this is an essential drugs. So what, as the Ministry of Health, what is expected is, I think the budget allocation should be changed from non-essential drug to these drugs. So I think the laminaria should be, and the other osmotic dilators should be put as essential drugs in the essential drug list.
So the other question is talking about, do we need more research just to understand cupping for women and teenagers, knowledge at practice about the availability of second trimester abortion care? Do we need to have that study?
Yes, yes. I think we need a lot of research. We need to have more research. What we have now was all the researches that shows why a woman will have why a woman stays till second trimester surgical abortion or second trimester abortion. So we need a research. One is, what's the factors? Why do they stay like till second trimester? And the other thing is, are they getting the service? Are they getting the facilities? And do we have even trained providers? And we should see also the value of the providers. Are they giving the service? So we should have a lot of research should be done on this. And unless we know what's the problem there, we cannot remove the problems. So I think one thing is we should know where is the problem.
Okay, I think that's absolutely relevant. Do I hear echo or it's just me? I don't know. Okay, so I think the issue of research is also very relevant. I think I am fully on board on that. We really lack local evidences. Most of the evidences are either from US or Europe, but when it comes to generating local evidences, we are really behind, and it's really something that we used to take for granted. But there are, based on our observations, there are some factors that can be addressed if that research is translated into policy. So if there are more questions, the floor is still open. I can see if there is any. I don't see any raised hands at the moment. I think there is one more question that is probably talking about counseling and informed decision making. If someone is requesting a second trimester abortion, how should we counsel them?
Okay, yes. Counseling a woman and give her to choose it's like empowering a woman. So it's not our mandate to choose for her, unless if there is some contraindication to do medical, or if there is some problems with doing the medical, we should give her all the choices, both the medical and the surgical. And with that, we should tell her all the advantages, all the complications, the disadvantages, and how the procedure is done in detail. And then after she knows that in detail with her language, then it will be her choice, unless there is some contraindications or other problem associated with doing a medical abortion. So it should be her choice. So with this, we can empower her. And then we should give her both options with telling the details of both of it.
Thank you very much. I think it's not only that we, even based on our national protocol, we just don't talk about we give them all the options, right? Even the option of if someone wants to continue even the pregnancy, that is as per our national protocol, that is always on the table. So all options of pregnancy continuation or termination will be offered, and that's what we actually call an informed decision making. So that is always part of the practice. So a few more questions. How do you think we can best get more providers? So the question is, how do you think we can get more providers to deliver second trimester abortion service? And what are the major reasons why providers are not delivering the service? Which values are in conflict?
Training, as we said, one of the challenges is we don't have the trained providers, and if even the number of providers we have for second trimester, both for medical and surgical, is very few. And the other thing, even the learning activity in postgraduate and also undergraduate class, it's more of a vacuum aspiration or more of medical abortion of first trimester. So this should be also this should be changed to have more training, and there should be a competency skill should be developed by undergraduate and postgraduate students on surgical abortion of second trimester and also on medical abortion of second trimester. And the other thing, we should drop the skill to less specialized staffs, like it might be health officers or mid-level providers. So we should drop the skill to that. And the other thing, even expanding the fellowship program of obstetricians on family planning and SRH. With this, we can at least increase the number of providers which are trained and skilled and knowledgeable.
I think that's really relevant in terms of making sure that women and girls have access to second trimester abortion services. And now we, in the past, this task sharing and task shifting was kind of restricted to the first trimester care, but nowadays evidence are coming, and even the most recent WHO recommendations recognize mid-level providers can be part of provision of second trimester abortion, be it in full or in part. So that is really relevant in terms of improving access. Again, that having a greater pool of trained individuals that can provide the service will have a great impact in ensuring access. Okay. Okay. I see one more hand raised. Kafli, Johannes, please go ahead. Kafli, you have your hand raised, your mic is muted.
Okay, can you hear me now?
Yes.
Okay, so thank you. First of all, I want to thank for this meeting. And my question is that, as Dr. Hanna said, most of the time, those particularly the surgical options, that's dilatation evacuations, it's only for gynecologists. So in the primary care, I think it would be better if we train those ISO and health officers to provide the service at those those facilities. So they can manage emergencies, and also they have an ultrasound there. Unless otherwise providing the service at the specialized hospitals only, cannot increase the accessibility of this surgical interventions. So that's one of the things that I want to comment. In the other is that most of the time I also train for the training, and midwifery have a master's in practice in childbirth. What I see is that most providers, particularly those who perform this procedure, they face, the procedure has its own limitations because you just crush all the fetal parts, evacuate the containers. So it's better to work on the VCAT for those providers in addition to providing directly the procedure. So that's my comments and my concerns. And the other is that there are a limitation on shortage of materials for providing the service. Some of the materials you cannot access them easily. So material shortage is the other reason for discontinuation of the service after we initiate it. Particularly, I just raised this as an experience from University of Gondar Hospital. Thank you.
Thank you very much. I think this is a very, really and honest and the realities that we face day to day. And I think if you have any reflections, Anna, you can go ahead.
This is a very good comment. Yes, this is what we face also. As we mentioned, all the challenges are it's really a challenge. So starting from the provider, it's not only the provider training, even though we have we trained a lot of providers, but still they are not doing they are not giving the service. So we should change also the attitude of the provider. So we need to have providers who have positive attitude. So one thing we should do is working on value clarification of providers. So we should work on that, especially when we give a training. We should also work on value clarification of the providers. The other thing, expanding the trained providers, and the other is the facility. Even though we have a trained provider with a good attitude provider, if we don't have a facility to do the procedure, or if we have a shortage of materials to do the procedure, still it's a challenge. We cannot go anywhere. So that's what we face day to day in our day-to-day activity. So this should be managed with a governance or a leadership. So budget allocation and also following the service like daily, it will change these challenges, I think. So this is a very good comment. Thank you.
Yeah, I think it is a very the very reality that we face every day. It's not only the obstetrician who is the forefront in managing such cases. The obstetrician will need to have the support of other mid-level care providers during the surgical abortion procedure, for example. So that also needs a good level of training, understanding, so that the assistant knows what is actually coming next during the procedure. So, and one of the things that we always face is staff turnover. So you have a good you work with a good team for about a year or two, then there will be a rotation. So again, or someone will go for a training, for upgrade or something. So in the meantime, that vacuum will be created, and you will have to start all over again. So that requires a sustained provision of level of healthcare providers that are committed to provide this service. So the task shifting and task sharing for DND, I think at this moment it is per our national guideline, it is to be done by an obstetrician in a hospital setting. So, I mean, this is based on what was the evidence at when the guideline was produced. So maybe down the road, it is something that the Ministry of Health can explore, whether it is something it is doable in our setting, or it is something that's going to be a bit, an area where we will need to see some concrete evidence whether or not we will be able to touch shift the procedure of DND to mid-level providers. Having said that, I don't see any questions. And I think we have addressed the Q&A. Just to a reminder, the recording of this video will be available, and a link will be circulated through the social media networks of SPIRH, as well as a website. So this will be available on the YouTube channel of SPIRH. So stay tuned for that link. Okay. I think we have addressed all the questions. I don't see red hands. I think having this session at this very time is very relevant for us, given the shortage of medication abortion commodities that we have at a national level. Thinking about how can we expand the availability of surgical abortion is very relevant, particularly in not only in Ethiopia but also in sub-Saharan Africa, where we understand how medical abortion commodities are becoming very difficult to get. So at least we have some sort of a backup for such cases. I think having said that, if you have any concluding remark, I will leave the floor for you, Dr. Hannah. If none, we will find out. Yeah.
Okay, thank you, Farid. So finally, what we want to say is, so it's clear we have challenges. We should remove our challenge, or we should, I think we should come over on our challenge. So second trimester surgical abortion, it's a vast topic. So, it was a very nice discussion. So you can get also this on YouTube. So we will have for time. Thank you very much.
Thank you, Hannah, and for all the participants who spare your time to join us on this lovely afternoon and be part of this discussion. We really thank you, and we will see you on the next webinar. Bye.